All right, in an effort to stay on time, why don't we get started with the afternoon session? Hopefully everybody had a good lunch. We'll do our best to stay on time here again. The afternoon session is entitled Supraventricular Tachycardias and Clinical Syndromes. I think it's a nice mix of topics here, a little bit of a potpourri, but I think these are all going to be interesting topics, and hope you enjoy them. First up is going to be Dr. Knight. He's going to talk to us about a very important topic, especially to the fellows, and it's on the efficient approach to SVT diagnosis and ablation.
All right, good afternoon. I give a lot of presentations on the differential diagnosis of SVT, and I have a long-standing interest in that. But what I'm going to focus on in hopefully 15 minutes is trying to cover the efficient diagnosis and treatment of SVTs. And I downloaded my talk on that computer specifically so it would work. My first slide is my disclosures. And although I am a consultant for many of the different companies and we receive grants from industry to support our fellowship, I don't have any equity or stake in any of the device or ablation or drug companies. Thank you. So here are my disclosures. So this was for the doctors in the room only. This is the comparison of the growth of physicians versus administrators, and I think this probably is obvious to a lot of people, but that's my first slide just to get everybody irritated. All right, so we'll talk about the efficient approach to SVT in the EP lab. One question often comes up is, do you use a 3D mapping system? I think that you can make a strong case for a 3D mapping system in even straightforward SVT cases to minimize fluoroscopy and to have better resolution of your location. I strongly encourage a single venous access approach rather than sticking multiple veins, IJs, other veins, and I think in almost all PSVT cases this can be accomplished with a single femoral venous access and occasionally a single femoral arterial access. I put in an RV catheter, a steerable quad in the high right atrium that can be placed in this coronary sinus if needed, but not at the beginning, and then an ablation catheter. And if they have documented tachycardia, and I'm confident that they'll have inducible tachycardia, I'll put an ablation catheter up at the very beginning through a long sheath at the his position, particularly if I'm pretty confident that it's going to be AV nodal reentry. If it's left-sided, you can go transeptal, still with 3 catheters. You can replace one of the catheters with an ICE catheter, do a transeptal, and still not have to stick another vein. Here's a retrograde aortic approach. There's a lot of talk about retrograde versus transeptal, but for pathways, often I'll still go retrograde. And then, one of my favorite topics is how do you efficiently make a diagnosis in the EP lab? You can pace the atrium, you can pace the His bundle, you can pace the ventricle, but if you induce tachycardia, I think the most efficient and diagnostic way to make a diagnosis is to perform overdrive ventricular pacing. The old school technique is to deliver PVCs and scan diastole with PVCs, but that requires very good sensing, and it takes a while to go through that, and often the tachycardia will terminate before you have the option of scanning the entire diastolic interval. And so you're really dealing with these 3 main mechanisms of tachycardia: AV nodal reentry, typical or atypical; AV reentry in the presence of a concealed or manifest accessory pathway with WPW, and then rarely an atrial tachycardia. I think the relationships of these, the ratios have changed over time as more patients with WPW have been ablated before they become adults. But this is still the 3 main mechanisms. There's other variants of the pathways. There's nodal fasciculars, there's junctional ectopic tachycardia, but of these 3 main mechanisms, that's really how you go into the EP lab. Initially looking at the substrate, what are the clues of whether they have an accessory pathway or whether do they have dual AV nodal physiology? Is there an accessory pathway? Is there a scar that might be a substrate for an atrial tachycardia? And then the second part really is just to induce the tachycardia and watch it. And you'll see cycle length changes, you'll see the development of bundle branch block, you'll see persistence of tachycardia in the presence of AV block. And here's an example of a regular narrow complex tachycardia with simultaneous atrial and ventricular activation, so it rules out an accessory pathway, and spontaneous termination with AV block as it slows. So when this happens, this really can only be typical AV nodal reentry. Other important observations, as I mentioned, are the development of bundle branch block. So again, remember that this is a nice example of a patient with a wide followed by a narrow complex tachycardia. These are the surface EKGs, His bundle, CS, and RV. And you can tell that with a left bundle branch block, the VA time gets longer compared to when there's no bundle branch block, and that's, as you all know, consistent with an ipsilateral accessory pathway and AV reentry. It also shows you that even when the VA time gets longer, the cycle length may not change because you get a compensatory decrease in the AH interval. And so that's why the cycle length here doesn't change despite an increase in the VA time. And for the fellows in the room, remember, it's not the local VA time, that's not going to change. The local VA time, particularly at the pathway site, isn't going to change. It's the surface EKG to the A. But I think if it's sustained and the differential diagnosis still hasn't been determined, then ventricular overdrive pacing is very useful, and we've shown this now many, many times that if you entrain from the ventricle and you conduct to the atrium and you get a VAV response that essentially rules out an atrial tachycardia, even if someone has dual AV nodal pathways, because in the initial study, we mimicked an atrial tachycardia with a pacemaker that we rigged with an EP catheter. We took an EP catheter, created an adapter, plugged it into a pacemaker, and mimicked an atrial tachycardia that would be suppressed with ventricular pacing in patients with AV node reentry. So even if you have an atrial tachycardia in a patient with AV node reentry, you should not get this response. The response is a VAV, unlike an atrial tachycardia where you go up, you pull in the A, and then it doesn't have another way to come back down. You get another A, V. So you will get a VAV response. And I think most people are familiar with that approach as they are with this data, that you can get additional information when the differential diagnosis, which is probably the most challenging one, is a septal tachycardia versus atypical AV nodal reentry. In this case, the VA time is very short, but if it's a little bit longer, it's important to determine if the ventricle is part of the circuit. And this early data showed that if the tachycardia mechanism involves a septal accessory pathway, that the post-pacing interval minus the tachycardia cycle length is going to be very short, less than 115 milliseconds, and if it's AV nodal reentry, it's going to be very long. This data initially looked very clean, but there's been many trial studies since then that have shown that with pathways, sometimes particularly if they're decremental, this can be long. But if it is short, it almost has to be involving the right ventricle, and that would be an AV reentry. And then furthermore, Greg Michaud published this concept, which even took advantage of that single pacing maneuver even more. So we're not just pacing and entraining the tachycardia, and we're not looking at just the post-pacing interval. We're looking at the very beginning where there's fusion. So here's pacing the ventricle during tachycardia at 250 milliseconds, during an SVT at 280, and you pull in the A here at 250. And we never really looked at this before, but it's analogous, if there's fusion, to giving a PVC on the His. And I think this is by far the most efficient way to make a diagnosis in these difficult cases, if you can get it to be sustained and overdrive pace. Because in this case, if you look, these are fused all the way until here. You don't fully capture the ventricle until here. So if you overdrive pace, you get to the atrium with fusion, it's equivalent to giving a PVC on the His. And what's also interesting is that if you have a very short VA time, every once in a while you'll be able to demonstrate this, and that's evidence of a concealed nodal fascicular pathway, which we don't typically look for. So I think this is the most efficient way to make a diagnosis, and then you can see in this case the distal CS was early, consistent with a left-sided accessory pathway. So remember, overdrive pacing the ventricle is the most quick way to do that. Once you've established the diagnosis, there's different strategies then that are dependent on the rhythm. AV nodal reentry is the most common. Most of this is pretty straightforward, but there are still challenging cases, and Rarely I'll still hear about patients getting heart block from a slow pathway ablation. The target, obviously, is the slow pathway, not the fast pathway, and this resides at the lip of the coronary sinus. We tend to target down here and kind of move our way up so that if we get junctional ectopy here and get rid of it, we're a little further away from the compact AV node. But often you have to work your way up closer and closer to the compact AV node. I tend to start this in the LAO view, localize the His bundle, deflect the catheter. Now that we use a mapping system, I'll create the geometry that shows you where the His cloud, so to speak, is, where the CS ostium is, where the cable tricuspid isthmus is, and then you've generated that anatomy, and you can rely on the mapping system a little bit more. And then we'll target initially the septum just outside the lower to mid coronary sinus ostium. And we'll look for a site with a fractionated atrial electrogram with a ratio of 1 to 4 or 1 to 8. You know, we say that number, but you know, this is kind of what you're looking for. You'll want a nice fractionated atrial electrogram and a large ventricular signal. You need a large, crisp V signal as an indication of good contact. And remember, because the tricuspid valve is a little bit displaced relative to the mitral valve, that ventricular recording that you're getting is really the left ventricle. And this is the fractionated electrogram that's probably due to slow conduction over that slow pathway during sinus rhythm. People talk about slow pathway potentials. You know, for typical AV nodal reentry, though, you don't see anything other than this highly fractionated electrogram. And this movie didn't play earlier, but here's an example of a 3D map during a slow pathway ablation. We don't tend to spend that much time in most cases generating this degree of anatomy, but I will always map this area right here, and we tag the His locations with the gold color, and then the RF lesions that were successful, that were delivered were in the red, with the successful lesion in the yellow. And again, looking for junctional ectopy, we're fixated on looking at the surface EKG and a channel, whether it's your coronary sinus channel or some other channel that has a very large atrial electrogram, so you can monitor VA conduction. If you don't get VA block, it's extremely unlikely you're going to get AV block. So I tend to deliver high watts with a relatively low target temperature. You rarely reach 56 degrees, but I'll deliver 50 watts, 56 degrees for 60 seconds. And I'll stop RF if there's no junctional ectopy in 20 seconds. If there's junctional ectopy with VA block, obviously. If you get PR prolongation, which would be rare without junctional ectopy. If there's instability of the catheter, or if anybody in the whole room or the whole hospital yells off, if I hear that, then everybody has authority to turn off the RF power. I'd rather come off and go back on. What do you do in the following scenarios? What if there's no VA conduction? Particularly with atypical AV nodal reentry, there may not be VA conduction. Some patients don't have VA conduction at baseline without inducing them with isoprel. It's difficult, I think, to ablate during isoprel. I would prefer to wait till the isoprel washes out. And so you can atrially pace as long as you recognize the difference between capture and the pacing stimuli with junctional ectopy. And very rarely you could use cryo, which doesn't result in junctional ectopy, and you can pace and determine if you got rid of the slow pathway. What do you do if several lesions have been unsuccessful? And that several is relative, but you can switch to a different catheter curve, a different guide sheath. You can target within the coronary sinus ostium. And I would say in the last few years, we've lowered our threshold to go to the left side. We've seen, I estimate that I've seen 6 cases that we've had to do a left-sided slow pathway ablation. And I think this one was at University of Chicago, actually, because you can see this is 47 RF applications have been delivered. And this was a successful site. You can go transeptal, or you can actually go retrograde, and you'll get the same electrogram appearance as you do on the right side. You'll get the same response. And in some cases, you'll give 40 lesions on the right side. You'll give 1 lesion on the left side, and it's gone. So there are definitely cases, whether they failed by you before, failed by someone else before, or you've been in the lab delivering a lot of right-sided lesions, to consider going to the left side. Some highlights about accessory pathway ablation. I think this slide's a very good slide because it emphasizes the challenges that we face and some of the issues related to approaches to ablation of accessory pathways. So you can see here's atrial myocardium, ventricular myocardium. This is the mitral annulus, and this is the accessory pathway. So we talk a lot about whether they're epicardial or not. Most pathways are not truly endocardial. They are all on the other side of the annulus, but you can get them from the endocardium. Occasionally, you'll have to go within the coronary sinus to ablate a pathway. But this also shows you why if you come retrograde and get underneath the aortic valve, you get good stability and heating, although it's harder to manipulate the catheter than if you go transeptal and you come up here. You can access the entire annulus more easily, but you tend to not have the same amount of contact and heating. So it kind of shows you transeptal versus retrograde and what kind of a very thin fiber. There's very few actually histological examples in the literature of an accessory pathway. Considerations are the catheterization techniques. We talked about that a little bit. Finding the pathway is really what we spend most of the time on. And in terms of avoiding complications, there's obviously pathway-specific considerations. Then there's the balance of efficacy and complications with RF delivery and energy titration. And then what are the reasons for difficult ablations? When we localize an antegrade pathway, someone with pre-excitation, I tend to do this just in sinus rhythm. Ideally, you record an accessory pathway potential, but what we tend to target is the earliest ventricular recording relative to the delta wave. That's your reference. In this study that was published by Hugh Calkins in the very early days of catheter ablation, when Hugh was at Michigan, electrogram stability was also a predictor of success. Often it's concealed and we're mapping the retrograde limb. And again, it's very important that you do this either during tachycardia or with ventricular pacing when you're certain that you're mapping the pathway. If you have a post-receptal pathway, you can't map the ventricle, you can't pace the ventricle and map the accessory pathway without being worried that you're mapping the AV nodal conduction retrograde. But in this study, recording of a retrograde pathway potential was a predictor of success, continuous activity during ORT or V pacing, and again, electrogram stability. This is pre-contact force. There's probably other things that are important considerations for success. Sonny Jackman really taught us a lot about the value of understanding that pathways are slanted. They tend to go around the mitral annulus in a clockwise direction from the atrium to ventricle. And it's important that when you pace the ventricle and you don't get a fused A and V, that you recognize that it could be because the pathway is slanted and that the true target is the accessory pathway ablation. But you can pace the V from different sites, and you can prove that the VA times are different and try to target the middle of the pathway rather than the ventricular or atrial insertion. I think this is sometimes just empirically doing this. You've given multiple lesions, they've had multiple procedures, and they can't get rid of an accessory pathway, knowing that they slant from the atrium to the ventricle. You can empirically sometimes come a little more clockwise and target the ventricular side. And then most people are aware that this is a challenging case, which are accessory pathways that can only be ablated from the middle cardiac vein. You can see here is an example of an ablation catheter deep in the middle cardiac vein. There isn't necessarily a diverticulum, but it's in the middle cardiac vein. And then reasons for difficult ablations. I wanted so badly for Fred to be here because I got this picture of him when he was a college student at UCLA, and this was not last year, this was not a couple years ago, this was quite some time ago, but when I worked with Fred at Michigan, he rarely wrote his own papers. He usually delegated that and was a senior author. But he wrote this one paper himself. He went through all the cases and deemed himself, these were difficult cases. Why were they difficult? And he concluded, based on the experience from about 200 cases, that inability to position the target site, which is a technical challenge, was a common one. Catheter instability, mapping an oblique pathway, or mapping error, failure to recognize a post-receptal pathway as being on the left side, other localization areas, epicardial location, recurrent AF occasionally happens or a complication. So what do you do about it? His, I think, nice way of saying get someone that's better than the guy holding the catheter was to change to a more experienced operator. It was a kind of a food chain where we just kind of went from one guy to the next guy or woman and try to get success with a different operator. But sometimes you need a fresh set of eyes. Change the catheter, switch from retrograde to a transeptal, switch from an inferior to, so occasionally accessory pathways are more amenable to ablation from a superior approach from the IJ. I routinely use a guiding sheath for all slow for almost all cases now, and I think they've evolved dramatically since this paper was written with steerable sheaths. More detailed mapping and the advantages of high-density mapping. Look in the coronary sinus for a pathway. If you have trouble with a left-sided accessory pathway, look in the coronary sinus. And the ones that I've added since this paper was published is considering cryo, irrigated catheters, or an epicardial approach. And then just finally, what are common errors? When you're measuring the AV nodal ERP, you have to block in the AV node. So occasionally people will reach the atrial ERP and then not move on to the next step, which is to give 2 atrial extra stimuli. And often people have jumped to the diagnosis that this is atypical AV node reentry and a bleeding and it won't go away, and really the mechanism was an accessory pathway or vice versa. Failure to recognize it's something that was diagnostic. Over-reliance on mapping systems, critical. You can't rely on your mapping system rep really in the differential diagnosis part of the procedure. Localization errors, catheter stability, failure to recognize the target on the left side, failure to monitor VA conduction compulsively during a slow pathway ablation. And then finally, the last one that I talked about was atrial tachycardias. We don't have time to talk about that, but high-density mapping, I don't know if that's going to be talked about over this whole, that's really changed, I think, what we do in the EP lab in the last year or two with these better mapping systems. And I'll stop there. Thank you.
Thank you. Probably have time for one quick question. We're running slightly over.
My nurse left during my presentation.
Do you want to make any quick comment about perihiscine pacing? Do you use it anymore now? We've gotten techniques where we don't have to use it too much.
Yeah, so perihiscine pacing is a good way to differentiate an accessory pathway near the septum that conducts more rapidly than the AV node. So I think people misunderstand that it's going to be useful in a long RP tachycardia where the pathway conduction may take longer than the AV node. So we do perihiscine pacing a lot before and after ablation still.
Thank you.
Thank you.